you have two types of insulin. You have a human insulins, you have analog insulins. We all know that human insulins are made up of by genetic engineering. It's very simple now because we don't use animal insulins anymore. We use more of human insulin. And we have analog insulin, as I told you, the three amino acids at the beta chain, the number 30, 29, 28, 309, lysine and proline. If you change them, you're going to get a analog insulin by changing the human insulin. So analog insulin is nothing but the change human insulin only, right? So whatever analog insulin you are using, they are just change human insulins, nothing else, right? Just they have been changed to change the pharmacokinetics and pharmacodynamics of insulin. So there's nothing new in the insulin therapy is the same. There's the same human insulin in a little chain form. Types of insulin, we have a mealtime insulin. Some insulins be used in a meal. Some insulin can be used as a basal insulin, which I talked to you about. The basal insulin is an insulin which is always present throughout the day in between the meals and the night. And you can use a premix insulin also, because the premix insulins help in giving you flexibility as far as the number of shots are concerned. So you have mealtime insulin like regular human insulin, analog insulin, Lispro, Aspart, and Glulysin. There are inhaled insulins also available, not available with us, but in US you have inhaled technosphere insulin, which is called Afrezza, which works as a short-acting, very rapid-acting insulin, and you have to go through you have to use as a nasal, like a nasal spray. The basal insulins like intermediate insulin or NPH insulin, which was there available with us earlier, and which was a human insulin, but in a protracted form. So and now it was not a complete or ideal basal insulin, but we have now newer insulin like Ditemir, Degludec, Glagin 300, Glagin 100. These are the kind of a basal insulins which we use now. Premix insulins, you have a regular premix insulin where you have a regular human insulin mixed with the NPH insulin, which is intermediate acting insulin, in the form of 30-70. So 30% is regular insulin and 70% is NPH insulin. Then you have a strength of 50-50, means 50% of this will be regular insulin, 50% will be NPH, and so on and so forth. Analog premix, again the similar way. Now analog premix, what is the difference? You have analog short acting insulin, right? But analog premix, you have protaminated insulin only. There's no change here. There's no analog, there's no second generation basal insulin only. Analog premix only, it changes the what we call as a regular, the short acting insulin. The NPH protaminated insulin remains the same. Remember this. So 30-70, 50-50, 25-75 will be the strengths in the form of how much short acting you are adding. Depending on that, you have a 30% long short acting, 50% short acting, and 25% short acting. And now we have a different kind of insulin, which is called co-formulation insulin. It is not a mixed insulin. It is insulin of with aspartate insulin and newer degludec insulin, which are very long acting, ultra long acting insulin. Okay, for half-life of 42 hours. So you have a combination of those two insulins, and this is real boon because you have analog short acting insulin and we have a real long acting insulin in this, which can help you control blood sugars very nicely. So better than premix insulin. It can't be called by premix insulin. It is a different insulin which is called core formulation insulin. Now you have insulin PK/PD comparison, and this is very, very important slide, because if you know the pharmacokinetics of the insulin, you know the when the insulin is going to start acting, you know when will be the peak action of the insulin, and how much time the insulin is going to act. You can actually place your insulin in the right way. This is very important slide. So because you can understand, if the peak insulin is peaking at 2 hours, then what time the insulin has to be administered within the food, before the food intake, and that will tell you, okay, 15 minutes, 20 minutes. If the action of onset is taking 1 hour to start action, then of course you have to give the insulin at least 30 minutes before the food, so that the patients, when you eat the food, then the glucose will start coming, and by the time insulin action is peaking or starting to act, the glucose is there in the blood. So you have to understand, and you have to think how the patient is eating a meal, what time he's eating a meal, and which insulin is right for this patient. That's very, very important. And what is the time when you have to give. If you miss this, and if you don't consider these things are important, you are mistaken, because if you miss the timings of insulin with the food, then there will be a mismatch between the food peak and the insulin peak, and the patient is going to land up with hypoglycemia. So you are not going to actually give him good control, but hypoglycemia, and the patient is going to stop taking insulin. So that's why I'm saying this is a very, very important slide, and you must remember what is the time of action, onset of action, how many hours the action is going to be there, and what is the peak action of this insulin. So if you see the analog insulin which we have, they will start acting within 25 minutes. Within 25 minutes, no time, they'll start acting, and the time to peak action is 50 minutes to 1.5 hours, right? So that means you can give in within 15 minutes prior to food, you can give this insulin. By the time the insulin is the food is speaking, the peak action will come at 50 minutes, and that's a very perfect peak for this. It will coincide with your food peak, and duration of action will last for 4 to 6 hours. Any human insulin, if you take short acting human insulins, the onset of action will be 50 minutes. So it will be till 50 minutes, it will take at least 50 minutes for the human insulin to start acting, and the peak action will be at 3 hours. So you can understand, see that your food peak and your insulin peak has to match. So that's why the human regular insulin has to be given at least 30 to 45 minutes before the meal. That's very, very important. And duration of action will be around 8 hours. If you take about U500, it is not available. It is very short acting. It starts acting in 25 minutes, same like analog insulin, but time to peak action is 4 to 8 hours, and duration of action is 13 to 24 hours. It's like an NPH insulin only. Only the time of onset of action is around 2 to 4 hours with the NPH insulin. So if you are giving this neutral protamine hegedron insulin, it will be acting after 2 hours. The time of action, peak action, will be around 4 to 6 hours. They say 10 hours, but by 12 hours action will generally go off. By 12 hours there'll be some tail remaining which will remain for 16 hours. So you have to give a second shot generally after 12 to 14 hours. Detimir insulin, Glargine U100, they start acting within 2 to 4 hours, and generally they are relatively flat, so you don't have time of peaking. Although they said the Glargine is peaks at 4 to 6 hours, but there's generally no peaking time for these insulins, and action is up to 24 hours. Glargine U100, there's time to onset of action is 6 hours. So it is 6 hours till this will start acting. It is a flatter insulin, completely flat profile. There is no peaking in this. The half-life is around 36 hours. Leg-to-leg insulin, similarly, onset is very fast in action, 1 hour, and this time to peak action is very flat. There is no peaking, and 42 hours is a half-life of the drug. So it will last for 42 hours. So those are the beauty of this second generation insulin, because long half-life, you can have a flexibility of injecting these insulins, and because of the flatter profile, the risk of hypoglycemia is very, very less. This is another diagram to just depict the insulin PK/PD. You can see the rapid onset, aspartate, lispro-glucin, inhaled insulin, how they are acting very fast and they come down slowly. You can see the long tail green color here. The green color denotes the human insulin, very long tail here. So the risk of hypoglycemia because of this long tail is very high. Remember, that's why most patients will have late hypoglycemia after food, because of this tail, which is so insulin is persistent in the system for many hours, even if the food peak or the glucose peak is coming down. Now you can have a missed short or intermediate action. You have intermediate NPH. You can see the dashed here gray line, which is peaking at around 4 hours, and then the action goes for around 12 hours. Generally, after 12 hours, the action wanes away, but some tail remains, which will remain till 15 to 16 hours. Long detimir, long U100, ultra long Glargine, ultra long degludec, everything has a flatter profile. You can see the action lasts for 24 to more than 36 or 41 hours for degludec. You can look at the single insulin profiles, how they're acting. So you can eat if you eat a basal insulin, the basal insulin is going to act like that. It's on a very flat profile. It's a long-acting basal insulin. You, with respect to the meal insulin, or with respect to meal, is going to be running like a flat insulin. You have a rapid-acting insulin, which is going to coincide with your food peak properly. So breakfast, lunch, and supper, dinner time. You have a premix insulin, analog insulin, which you can give before breakfast and before supper time. So the short acting component, this is the way the profile will be there. The short acting component will work on the meal, and the long acting component is going to act as a basal insulin, which is going to work for at least 10 to 12 hours, and the next shot will be required after 10 to 12 hours. And you can see again the short acting insulin will work as a meal insulin, and the long acting will work as a basal insulin. So this is how the analog insulin, 5 to 15 minutes before it will be onset will be there, and duration of action will be 10 to 16 hours. Intermediate action, you can see the peak will be at 2 4 hours, and by 12 hours action generally goes away, and then the next shot is required before another meal, so that the basal insulin is maintained in the system. Then you have a short acting insulin. You can see the short acting insulin with your human insulin, but it's, you can see the physiological peak of the food. The peak of the food is getting over, the insulin is not rising, matching the regular human insulin never matches the peak of the physiological peak of the food. So always there will be risk of hypoglycemia, where in this section where the blood sugar is dropping and the insulin is remaining in the system, and hence you have to be very careful, and the timing of the human insulin has to be very perfect. And again, the premix in an insulin, human insulin, is going to works in a similar way, but because of the long tail of human insulin and NPH insulin, the risk of hypoglycemia with the premix human insulins is going to be always on the higher side. So remember these points. And since now we have ended the summary of insulin profiles, I'm stressing because if you know the profiles, you can use your insulin wisely. Rapid acting insulins can control your postprandial hyperglycemia. Remember, rapid onset, maximum peak, and shorten of duration. Aspart is used and approved in broad range of populations like pediatric, geriatric, pregnancy, everywhere. Kidney and liver impairment, hospital and pump use also, you can use aspart insulin. Then you have intermediate and long-acting insulin like Glargine, Ditimir, and Deglutec. These are long-acting insulins. Will look at the fasting hyperglycemia. So remember, basal will act on the fasting hyperglycemia. So you can want to control blood sugar fasting, you use a long-acting insulin like these. Relatively slow onset and duration of action is more than 24 hours. Flat and stable glucose lowering profile with least variable, and duration of action is more than 42 hours for the Glargine 300 and Deglutec insulin. Then you have a premix insulin like human and analog premixes, which I have told you that one of the component will act as a short acting, which will take care of the postprandial component, and another one can control your fasting also. So suppose you want to control one fasting sugar also and post breakfast sugar also, you can, or post dinner sugar also, then you can give one shot in the night, so that will take care of the post dinner sugar, the short acting component, and the long acting component is going to take care of the fasting blood sugar. With single shot you are able to achieve both the sugars right. Then you have a co-formulation insulin, similar way, but it is a different kind of insulin. It is not mixed, they are not together, but still they act together. 30% of aspart insulin and 70% of Deglutec insulin, co-formulation insulin, 24-hour coverage and one meal coverage you will get with this insulin. So there is absolutely a very good insulin, and it is the pharmacokinetic of the insulin is not changed in the liver or kidney disease. So you can safely use this insulin, co-formulation insulin, in kidney or liver disease. But this is about the premix insulin, which we talked about. The insulins, how they appear. Generally, the premix immune insulins or mixed-art insulin or 50-50 insulin, they are all cloudy and you have to shake before use. And they have a dual peak of action. So one will be short-acting component, so one peak, and another peak for the long-acting. So there will be two peaks. So you have to remember that when you are using the insulin with two peaks, the risk of hypoglycemia is more. Why there is a risk of hypoglycemia? Because the insulin peaks and falls. So whenever there's an insulin which peaks and falls, is going to cause hypoglycemia. All right. So, and if it doesn't, there's a mismatch between the insulin peak and the food peak. This is the thing you should remember. So these insulins have two peaks. Biaspart insulin, Novorapid, you know all that. Aspart protamine, aspart protamine, and aspart insulin. You have a onset of action less than 15 minutes. Again, dual peak. You can use once a day, twice a day, or thrice a day, and it's always cloudy. Then you have a Humalog mix, again basic Lispro insulin, similar kind of insulin, and you have a Zyzodec insulin, which is not a cloudy but a clear solution. So this is a difference between the premix insulins and this co-formulation insulin. This is a very, very clear solution here.